In this chapter, we will discuss the tooth preparation for ceramic restorations. The ceramic restorations involve the full crown, inlays and non-lays, and the laminate veneers. We will see some indications, contraindications, the procedure of the preparation, and some tips with some clinical cases that will be discussed throughout the chapter. The tooth preparation roughness does not provide improved retention. This is the first advice that they are emphasizing, that the smoothness of the preparation is so important to get a smooth finish on the tooth preparation, which improves the accuracy of the fit and delivers a thinner cement space, which decreases the micro leakage. When we have a tooth preparation that depends on adhesive resin bonding, it should be etched first and be prepared for the cementation. So the preparation must have smooth surfaces, round line angles, and precise flowing finish lines. When we are going to choose a ceramic type, we should make sure that it can be adhesive resin bonded, which that we can couple between the ceramic and the tooth that we are going to restore. Now let's see some considerations of the preparation. If we were preparing a tooth and for a crown and we had an undercut, we can block it by using a composite resin base. As for we are preparing a crown of an anterior teeth, starting like we are preparing for a veneer makes us have a more conservative result. Here, for example, although we were preparing a full crown, we started with preparing for as of we are doing veneers by using the depth burrs. Here we can see a case of a maxillary first premolar that had an endodontic therapy. We took the shade before the tooth preparation. We removed the MOD restoration and did an occlusal reduction. Then we did a complete buccal veneer that with a 0.3 subgingival finish line. We did not do any lingual tooth preparation, and a pressed lithium disilicate was used for the restoration. Another case of a mandibular, premolar and molar, where we did a minimal finish line, and we used a ceramic onlay for both. There is a rule that we should not exceed a thickness of 2 to 3 millimeters of ceramic. Otherwise, zirconia restorations should be used, although they are not etchable. An airborne particle aberration or a phosphate-based adhesive blotting agent is used. The onlays and inlays are contradicted in situations where we have high occlusal load and a reduced aesthetic demand. In this situation, we use a metallic ceramic restoration where we have a metal occlusal surface, and this treatment has shown an excellent long-term success rate. Here we see a case of a tetracycline stained teeth that was restored by a composite resin veneers. Then they were removed, and the tooth was prepared minimally, only in the labial side. Then we did what is called an interim restoration by direct composite resins. This is it. Now let's see how we prepare the veneers. First of all, we do a 0.5 millimeter depth cuts using the burr cut. Then we reduce the chamfer ended diamond to reduce the depth. Then we finish the facial reduction by this stage. We then proceed to the incisal reduction by 1.5 millimeter, and we do what is called an elbow preparation, that in the proximal contacts, this is it, number G here, we preserve the proximal contact. Then we do an interproximal stripping, this is it, with a diamond strip to refine the elbow. Then horizontal, but we make sure that the effective side faces the teeth and the safe side does not cause damage to the adjacent teeth. This is something they mentioned, that they used a horizontal sitting groove in the labial side to act as a guide for the veneer to have a one path of insertion. Then we finished the preparation. This is the labial view, and this is the lateral view, and this is the occlusal view. Veneers are highly recommended for diastema closure, where we should make a wrap of the finish line from the gingival sulcus toward the lingual side of the tooth to allow the development of new axial contours, which means we extend the finish line to the lingual side to have more space and to redo the contacts points again, and to close the proximal contact without creating any periodontal compromise. We have discussed before that the finish line for the veneers is the feather edge finish line. If we have no modification that is indicated for the incisal reduction, that we only do a facial surface preparation only, but when we need to do the incisal reduction, we do 2 to 3 depth cut grooves in the incisal edge with a 1 millimeter diamond rotary instrument perpendicular to the long axis of the tooth to get an overall reduction of 1 to 2 millimeter that is flat and perpendicular to the long axis of the tooth. In the case where we have an opposing tooth that occludes on a ceramic margin, and this is forbidden, or when we have a lingual surface that need to be restored, we do an additional lingual reduction. How will we do it? By using a football-shaped diamond rotary instrument for the lingual reduction by 0.8 millimeter depth. After we finish it, we must ensure that there is a clearance in all mandibular movements by 1 millimeter to ensure that there is an adequate room for the ceramic in all load-bearing areas. So the goal for the lingual reduction is to restore the affected tooth structure and gain a prosthetic space for the ceramic to completely restore the occlusal contacting area. Here in this case, we see that the anterior teeth are attenuated and we have a midline diastema with malocclusion and apparent gingival margins. When we did the veneer preparation, we extended it to the dentin to gain more restoration space while preserving the lingual tooth structure. Then we did the cementation of the final veneers. Now, can we use the lithium disilicate for the posterior portion? The answer is yes. The most two popular ceramics for the posterior complete crowns are the zirconia and the lithium disilicate. The hot pressed ceramic crowns or the max pressed, like the Evoclar and the Amherst, they are usually about 1 to 1.2 thickness, needed to create an aesthetically pleasing restoration, and they can be bonded to the tooth. On the contrary, zirconia does not get any bond. So this is the recommended reduction of the ceramic crowns. The incisal edge is 1.5 millimeter, and the finish line from both the lingual and the buccal is 1 millimeter. These are the armamentarium for a ceramic crown preparation, where we do the proximal surfaces and we do the finish line with these, and the lingual side with these. For the crown ceramic preparation, we use the chamfer finish line or the shoulder. As for the chamfer, if we want it to be modified to extend it to the subgingival margin, we do first primary preparation of the finish line, then we add a displacement cord and redo the finish line and extend it more in the subgingival margin. We can do a 90-degree or a shoulder finish line. It is more aesthetic because it provides more thickness of the ceramic, but we must sure that no residual unsupported enamel to be left, because it will be easily chipped off. So the chamfer finish line must be 1 millimeter wide, rounded internal angles, smooth and continuous. Another type of ceramic restorations are the inlays and the onlays. Here they are saying that they are bondable restorations and that will reinforce the weakened tooth structure and enable more conservative tooth preparation. This has been denied by some studies, and some studies support this statement. It's not a fact. They are usually cemented with the acid etch technique, when we add where we etch the two teeth and the restoration. Then we add a coupling agent for both the teeth and the restoration, and we do the cementation. They have shown promising longevity from 8 to 10 years of performance, with a survival probability of 80 to 95%. They are indicated where we have the size of the defect is beyond what can be restored with a composite resin. In the same time, it is small enough to be indicated for a complete crown. In this case, the ceramic inlays or onlays is indicated. As a general rule, where we have a cuspal coverage restoration, the composite resin is not recommended, and we search for another option of treatment. So the contradiction of the inlays and the onlays is when we have a poor oral hygiene, active care, bruxism, and when we have two-thirds of the occlusal table that is missed. The onlays and the complete crowns are preferred over the ceramic inlays where they provide more retention. They are emphasizing on the importance of the final polish of the tooth structure to improve the restoration steps from the lotting to the to trying and finishing and all the other steps, and to achieve a periodontal relationship that is optimal. To take perspective of that the ceramics are brittle, so the removal of sound tooth structure may be necessary in order to ensure we have an adequate thickness for the strength. This is a case of a mandibular first premolar ceramic inlay. We have a defective restoration and caries. We did the preparation and it has a specific characteristics that will be discussed in a minute. Here we see the digital scan, and this is the final restoration. This is another case where an MOD amalgam restoration was replaced with a lucid reinforced ceramic restoration. These are the armamentarium of the ceramic inlay preparation. We see the red burr for the finishing, and we see the rubber burrs also, and the brushes which emphasize the importance of finishing the restoration and the preparation are so important. Now let's see the guidelines for the ceramic inlays and onlays. This is important. The pupil depth is 1.5 to 2 millimeters. We must have round internal line angles. The axial wall convergence is 10 to 12 degrees, and the axial wall reduction, which is the boxes, is 1 to 1.5 millimeter. The azimuth is 2 millimeters. The occlusal reduction is 2 millimeters, and we have smooth margins with no sharp transitions. Here we have round angles. The azimuth is 2 millimeters. The convergence is 10 to 12 degrees, and the axial wall here or the box here, it is one height, and its height is 1 to 1.5 millimeter, and this is the depth is 1.5 to 2 millimeter. Shoulder 90-degree margin is indicated for the inlay ceramics. The bevel margin are contracted because bulk is needed to prevent the fracture. We cannot overemphasize the importance of finishing. The margins in enamel must be smooth and distinct for a ceramic restoration to fit accurately. We must take our time to do the finishing really properly, using the burrs and the rubbers and the strips also. They repeated the occlusal clearance idea, where we have 1.5 millimeter of clearance in all the mandibular movements to prevent any fracture, that we have enough space for the restoration to be built that will not cause any occlusal interference. It can be evaluated by measuring the thickness of the resin interim restoration with the dial calipers. So we said that we have ceramic crown preparations and an inlay only preparations and laminate veneers preparations. We have seen the indications, the contraindications, the tips for the preparation, and we have seen the cases. You can screenshot the tables for the summary of what we have said. Salam.